So with that, let's go ahead and proceed with Brian Shepard. And Rebecca, I think we have slides for this. Is that right?
That's right, and I think Brian is going to share his screen.
All right, so let me just introduce Brian Shepard, who is the CEO of the United Network for Organ Sharing, UNOS, and the Executive Director of the Organ Procurement and Transplantation Network. Thank you, Brian, for being with us today, and I look forward to your comments.
Thank you, Mr. Chairman, members of the committee, and this is a very important topic, and it's our pleasure to have an opportunity to address you. I know that there's a lot of expertise on the committee, some of it very donation and transplant specific, and some of it not. So I know some of you will know parts of this. I hope there's something in here for everybody. And I'm going to try to give a very high level overview of some of the issues that you might want to consider. I will say in some cases I'll use an example that might be specific, but what's important I think is the concepts and some sense of scale, and that's what I'll try to cover today. Get that slide to move. So first, a few things about that sense of scale. In the last year in the United States, we've done just about 40,000 organ transplants. That's about the same number as the prior year, and that's about a little bit more than 40% higher than in 2012. Those transplants are made possible by nearly 12,000 deceased donors, and last year, over 7,000 living donors, although this year's number is going to be somewhat smaller than that. That makes the United States system the largest system in the world, and even by population-based metrics, the most effective system in the world. Spain has some similar transplant rates for population. No one other than that approaches the American system. Just to take a quick diversion into COVID, these two lines represent transplants throughout the course of the year in 2019 in green and in 2020, this year in the purple. And you can see there the March-April dip due to COVID. That number dropped to maybe 50% of what's our expected national capacity and stayed low for 6 to 8 weeks. That is, even with the size of that drop, that is a smaller drop and a quicker recovery than our colleagues in other parts of the world saw this year in COVID. And so the result of that rapid recovery is that deceased donor transplants are actually higher this year, despite that period of time when COVID was earliest and most difficult to manage. And the total number of transplants will be slightly lower this year as living donation has been postponed in many cases for candidates. So you can see the living donor line is lower than last year. And to one of the committee's questions a moment ago, while no donors who are COVID positive are no potential donors are being used for donation, there are now just the beginning of candidates whose organ injury was caused by COVID. So folks who have had COVID and had, in most cases, lung damage due to that COVID infection are now getting transplants as a therapy for their prior infection. This page is really to help take a look at the scope of the donation and transplant life cycle, and I hope that it may either be inspiring or daunting. It's certainly possible for the committee to address issues at any point in this, although I think the scale is so large that the committee could also get lost trying to address too many things at one time. And so I'll point out just a couple of things. The process starts with the patient. Obviously, you must be on the waiting list to be allocated an organ. It seems obvious. Some of the conversations about access to transplant certainly involve the opportunity to get on the waiting list, allocation policy can only deal with those folks who are on the waiting list. There are lots of barriers in healthcare that are not transplant specific about getting to a hospital and receiving care. The transplant is not exempt from any of those challenges, and I think that's an area worth a lot of study and a lot of work. But the wait list itself can only affect those folks who are listed. The transplant allocation system can only affect those folks. The right organ is about identifying organ donors, about communicating them effectively from the donor hospital to the OPO, and entering that information into the system. We have advocated for automated electronic donor referrals. There are some examples of that in some parts of the United States that seem effective in communicating that information, which not only potentially improves the donation process, but also creates a data set to help evaluate OPO performance that I think is potentially stronger than the data set in the new rule, and is something we could look at in the future. Those two things together come to the match run, and I think the match run is really where this committee's charge seems to be pointed, and it certainly is most of the work that we do. And so I'm going to spend most of my time in this introduction coming back to the match run. But just to point out, there are issues worthy of study and action, and our organization is doing some of that in the way that offers are sent and evaluated, examining, conducting and applying behavioral research to the way that clinicians review offers and how they make the decisions. OPOs recover nearly 20% more kidneys than are actually transplanted. And so how can we affect the decision-making process and increase the utilization rates there? There are logistical and clinical challenges with having made that match, actually implementing that information, actually putting the transplant to use. We're developing tools to share images and information from the donor OR to the waiting recipient transplant team, developing GPS tracking systems to monitor the timing and even sometimes potentially clinical information about the organ itself while it's traveling, and then metrics to monitor the performance. But again, we're going to spend most of our time here on the match run itself. So who are we to be doing this and answering these questions, and why am I the one that's here in front of you today? Well, the OPTN was created according to congressional action in 1984, the National Organ Transplant Act that calls for the creation of an OPTN, which is a nonprofit organization made up of the donation and transplant community and their patients, in order to develop these types of policies. All transplant hospitals in the United States are members of the OPTN. All the OPOs in the United States are members of the OPTN, and also histolabs, some donation and transplant related businesses, and some patients. Our board of directors is made up of practicing transplant clinicians, as well as OPO staff and patients. And so are our board and committees. Now, we are not the only organization that makes rules that affect donation and transplant. We have exclusive authority over allocation rules. Safety is really implemented in a couple of ways. CMS has rules about certification and payment, and some and their consequences can be significant. We have a peer review system that I think works well in concert with that. I think the system is better off having both a high consequence, bright line performance enforcer and a peer-driven performance improvement organization. And we are, to the extent that we're involved in safety and performance, we are that peer-driven organization. And because all of this takes place in the broader context of healthcare in the United States, the entire field is regulated or influenced by FDA, CDC, NIH. and certainly lots of other federal involvement. UNOS is the nonprofit organization that serves as the OPTN. We have that designation by contract. It is not a permanent designation. That contract is rebid from time to time, usually about every 5 years. And during that period, we serve as the OPTN. If the next RFP were to select another organization, they would then take that role. Dr. Odom showed us this slide earlier about OPTN policy development, and I want to point out just a couple of things here. In those first three buckets, we're really talking about the prioritization process. There are lots of ideas about what to do first, what to do next, how to improve the donation and transplant field. And we do that through the committee process and through a policy oversight committee, which is in fact a committee of committees. The theme in this policy development process really is community involvement. It is the folks who do this work and the folks who are affected directly by it that write organ allocation policy, and the organ-specific committees, the constituent committees, and then the POC, the committee of committees, the policy oversight committee, drive the selection of projects to work on. Evidence gathering, that step is all about data. We are a highly data-driven organization. Because of our role serving as the OPTN, we have data on every organ donor, every transplant candidate, every transplant recipient in the United States since the 80s. And we use that data to predict the outcome of policies. There's another government contract to an organization called the Scientific Registry of Transplant Recipients, the SRTR. The SR does modeling on behalf of our committees to help predict the outcomes of potential policies that they might consider. The sixth step at the bottom of the circle there is public comment. Every allocation policy goes out for public comment. Public comment is a critical piece of the policy development process. No policies are adopted without hearing from the transplant donation community public and the public at large. We hold regional meetings across the United States. We collect public comment on the OPTN website, and that comment is very seriously considered and taken into account by our committees. Policies, once they have been sort of nearly finalized by a committee, are recommended to the board of directors. And as Dr. Odom pointed out, the board is broader than the committees. The board is made up of transplant professionals from all organs and OPO professionals, and a quarter of that board of directors are patients. That's a requirement in the statute. And while there is patient involvement in the committees, and certainly some patients comment in public comment, having that patient voice as a quarter of the board of directors is really critical to ensuring that not only the clinical characteristics of the policy are correct, but the broader ethical considerations are also taken into account in the way that the community expects those to be. And so I know one of your charges is about whether the board takes into account the work of the expert committees, and no policy proposal can get to the board that has not come from a committee. But that does not mean that the board is subject then only to the committees, and the board is intended to apply its judgment, its broader perspective, and to be the final decision maker. That's what was set up in the statute. That's what's set up in our bylaws and processes, and that's intentional. They absolutely take into account the committees, but there is this second broader step, and it's there for a reason. And then finally, data again, as every policy goes into effect, is continually reviewed by the committee that sponsored it to determine whether it's meeting the goals, to determine whether anything new has taken place that the committee had not foreseen, and is able then to take those results and determine whether future policy development is necessary. Just as a parenthetical, all this data in also means data out. The SRTR, as I mentioned before, also performs analyses on Transplant Center and OPO performance. We also provide a number of tools to programs and OPOs to measure their own performance and their understanding of their system. Now, there are a number of places that our fundamental principles come from. And I will say first that these are not equal in dignity. The National Organ Transplant Act is an act of Congress, and that in the event that it ever conflicts with any of the lesser documents, it trumps those. The final rule is a regulation promulgated by HRSA that trumps decisions that are made at the OPTN level. But then the OPTN also has sort of attempted to fill in the gaps with ethical principles and then ultimately with policies themselves. NOTA calls on the OPTN to assist organ procurement organizations in the nationwide distribution of organs equitably, and that's important. And if you look at the early drafts, you can see an evolution from an early call for an OPTN that would help OPOs if they could not place the organ locally. But as the statute was developed and as it was finally passed, that language shifts to an OPTN that is intended to promote a nationwide distribution, that is intended to promote equity, and calls out specifically some populations with special needs. The final rule promulgated by HRSA adds a little bit more detail to that, calls for medical judgment, calls for best use, as specific language intended to make sure that the transplants are effective, to not do futile transplants, and also the final rule in the regulation emphasizes that geography is not intended to be a factor in candidates' access to transplant. The OPTN Ethics Committee has promulgated a white paper, and they've actually updated it several times over the year. I know Dr. Gordon, this committee has been a past chair of that committee and involved in that sort of work. The Ethics Committee has talked about the balance between utility and justice or equity, how to not only get the most benefit, but to make sure that that benefit is distributed in a way that meets the values of our community, and doing both of those things in a way that respects individuals and respects autonomy. So how are we doing on these, on balancing all these things? There were some questions, I think, earlier that can be answered by this calculator. I'm going to send some links to Rebecca in the future that she can share with the committee to find some of these data slides and go back and take a deeper dive in this. This we can actually provide as a live interactive document. But this equity dashboard was designed by statisticians in our research department to look at, all other things being equal, how much difference does it make whether a person is in a specific donation service area, or is highly sensitized, or is of specific blood type, or has had a kidney transplant in the past. And if you go down that scale, you'll actually see ethnicity, community risk score, gender. Those tend to make very, very little difference in your access to transplant, which is good. That's what we're looking for. We still certainly have donation service area, but there's a new policy in kidney about to take effect that changes the geography that hopefully will drive that bar down in the future. In practice, balancing all these principles tends to create sort of really complicated layered priority lists. And this is, again, an example not for the purpose of understanding exactly how we've assembled all these priorities, but to see how a list can get constructed. Each patient on the list belongs in one of these boxes, and only one of these boxes. And so this list prioritizes for the very best kidneys. KDPI is a measure of the quality of the kidney, and the lower the number, the better the kidney. So the highest quality kidneys first go to the very hardest to biologically match, the 100% highly sensitized, then to the nearby prior living donors, then to the nearby pediatrics. And you can see through all of these boxes, you proceed down that list in that way. What that creates, though, while the boxes are that there are clearly a large number of boxes, which helps to make this a granular and specific system, you cannot get from one box to another box. You cannot. There's nothing about a candidate in one box that can make them move past the other box. So the system has boundaries in it, and that's going to be important to talk about continuous distribution as we close out here. One boundary that that certainly gets people's attention is geographic boundaries. But as you saw on the prior slide, there are age boundaries, there are sensitization boundaries, there are blood type boundaries. This is the map that drove most organ allocation for most of the time that allocation has taken place in the United States. This is a map of the donation service areas in the United States. We have moved all of the organs, including kidney and pancreas, which is board approved and about to take effect, although that policy has not yet taken effect, have moved to a circle-based allocation policy. And so those, there are still boundaries, although those boundaries are somewhat more intentional and somewhat more tied to the length of time that an organ might spend on ice as it travels. Moving to a continuous distribution model means taking these criteria and trying to create a total score. So taking the urgency of the patient, their likelihood of living beyond their transplant, some biological factors, special access factors like pediatric status, and the efficiency of the placement transportation process. We come up with a single score rather than that series of boxes. And this lung example is not important for understanding each of these 9 boxes. But for example, the top left box is medical urgency. And so the fewer days you are expected to be able to survive the wait, the higher your score is. The next box over on the top is the post-transplant outcome box. So the more days that you're expected to survive past your transplant, the higher your score will be. Some categories are really categorical. In the pediatric category in the upper right, if you are pediatric, then you get all the points for that priority. If you're not, you get none of them. And so on. The travel and proximity categories at the bottom are sliding scales where you get fewer and fewer points for being further away. The lung committee has looked at each of these and is working on a proposed policy that takes the score from each of those boxes and multiplies it by a coefficient, weighting how important that factor is in a candidate's place on the waiting list. And so if you take the coefficient for each box times the score in that box, you end up with a sliding scale. And so each candidate on the list, rather than falling into a box that describes the category, has a score based on all of the factors and all of the formulas that have gone into describing their condition. That's the direction that policy is going in. I think that's probably worth a longer conversation with you, but that's just a sense of how that type of distribution would work and how that would, in fact, make it easier in the future to make small adjustments to coefficients, to make small adjustments to the underlying formulas, and have a more responsive, more fine-tuned, more rapidly changing system that adjusts to the conditions and our observations of the environment. So again, thank you for your time. That's a very high level look at allocation policy and how it is made in the United States. I would commend this slide to the committee as a way to think about what parts of the system you might want to spend your time on, and I'm happy to take any questions that you have.
Thank you, Brian.